End ileostomy, described by Brook in 1952, also known as Brook end ileostomy, is technically simple procedure, and to this day it remains standard technique for constructing an ileostomy. Consider this as an ileostomy model with anterior abdominal wall and ileum with mesentery. End of ileum for ostomy is prepared with adequate vascularity by preserving arcade of blood vessels. At least one optimal site for stoma is marked prior to surgery if planned for ostomy. Most commonly chosen stoma site is outer third of rectus muscle at the summit of infraumbilical fat pad. Ileostomy is usually placed in right lower quadrant and colostomy is placed in left lower quadrant. At the marked site, skin is holded with Allis forceps. A 1.5 to 2 cm circumferential incision corresponding to size of bowel is made using electrocautery or scalpel. Incision deepened vertically into subcutaneous tissue up to the anterior rectus sheath. Coin or disc-shaped subcutaneous tissue with skin is dissected free from anterior rectus sheath and removed as whole. A vertical incision is made on anterior rectus sheath and underlying rectus muscle fibers are visualized. Rectus abdominis muscle is split along the direction of muscle fibers to expose posterior rectus sheath using artery forceps. Care is taken to avoid injury to epigastric vessels. If unintentionally injured, can be ligated. A transverse incision is placed on anterior rectus sheath to create a cruciate opening. Posterior rectus sheath and peritoneum is visualized and divided as one while preserving underlying bowel with hand or laparotomy pad. The opening created should allow passage of 2 fingers, but it may vary according to the habitus of patient and edema of bowel wall. The mobilized small bowel is exteriorized by holding with Babcock's forceps and examined for viability and tension. Care should be taken to avoid twisting of mesentery. Adequate length of bowel for about 4 to 5 cm is taken out to avoid flat stoma. 3 to 4 interrupted sutures are placed between anterior rectus sheath and seromuscular layer of bowel. Sutures are taken on antimesenteric border and on sides of bowel to avoid injuring mesenteric vessels as it may compromise stoma vascularity. Care should be taken not to penetrate bowel mucosa. Accidental full thickness bite can lead to intracutaneous or parastomal fistula formation. Absorbable suture material 30 Vicryl is commonly used. These sutures prevent retraction of stoma, intraperitoneal slippage and reduces tension on mucocutaneous junction. Tripartite sutures are placed containing dermis of skin, seromuscular layer of bowel at the fascia level and full thickness bite at cut edge of the bowel. Sutures are not tied and holded with artery forceps. For ileostomy, proximal seromuscular bite is taken at 4 cm from cut edge, and for colostomy it is at 1 to 2 cm from cut edge. 3 everting sutures are placed first away from the mesentery using 20 or 30 silk. Bite at mesenteric border is avoided to prevent vascular compromise and bleeding. Thus, tripartite sutures are placed circumferentially in between first sutures except in mesenteric side. After placing all the bite, sutures are tied to avert the bowel. This aversion of stoma prevents skin excoriation, decreases risk of mucocutaneous separation, facilitates drainage and allows easy monitoring of stoma viability. In mesenteric side, mucocutaneous sutures are placed between cut edge of bowel and dermis of skin. Sometimes after placing 3 to 4 tripartite sutures, bowel is averted first and 4 to 8 mucocutaneous sutures are placed circumferentially in the gaps. The bowel should appear pink and protrude 2 to 3 cm beyond the abdominal skin. Ostomy bag is placed over stoma site. This completes end ileostomy. Thank you.